This Week in Virology, the podcast about viruses, the kind that make you sick. From Microbe TV, this is TWiV, This Week in Virology, episode 1158, recorded on October 17, 2024. I'm Vincent Racaniello, and you're listening to the podcast all about viruses. Joining me today from New York, Daniel Griffin.
Hello, everyone.
Who's wearing some repetitive pattern on his bow tie.
Yeah, I don't know if you can zoom in on this. Can you see that, Vincent? I think it would do Dixon proud, if that's a hint.
Is it trichinella?
Yeah, so it's not a doctor cell, it's a
nurse cell.
Nurse cell. I was a little disappointed because I was wearing this today in the ICU and everyone just seemed baffled. What is that? I'm like, oh my gosh, they're not teaching parasitology in the medical schools anymore.
They're not?
They're really, it's just such a minimal amount. It's a shame, right? It's so many other things have filled that part of the curriculum. When you think about this world that we live in, right? I mean, how many people are suffering from parasitic diseases? And so,
I mean, Dixon used to teach a lot of parasitology to medical students, right?
So there was a whole course, and actually, our listeners may or may not know, but Dixon was one of my parasitology professors at NYU when I was at NYU School of Medicine. There's a whole section. People used to love it. And then it sort of slowly got shrunken down into some visiting person comes and gives maybe 8 lectures, and then you move on. And
well, it's the whole thing of U.S. centrism, right? They don't worry about parasitic infections in the rest of the world.
Yeah. But we got plenty of our own here, but let's jump into it. And I have 2 quotations this week, right? 2 for the price of 1. One by Ray Bradbury and one by Abraham Lincoln. So let's start off with Ray Bradbury. People ask me to predict the future, which all I want to do is prevent it. Better yet, build it. Predicting the future is much too easy anyway. You look at the people around you, the street you stand on, the visible air you breathe, and predict more of the same. To hell with more. I want better. The most reliable way to predict the future is to create it.
Yeah, I like that very much.
Yeah. I mean, I really think that's you and I are talking about what's going to happen this winter. But, it's within our control. People can make smart decisions. We've got tools. All right, let's jump into several things to talk about today. Mpox, right? October 14th, the WHO announced the approval of Bavarian Nordic's Mpox vaccine, Jynneos, for adolescents aged 12 to 17. Actually, Kathy Spindler sent me an email earlier today with some of the data on this. But we read in CIDRAP, I'm going to give a plug for CIDRAP here, that the move comes as the outbreak in the Democratic Republic of the Congo is still raging and infecting children at high rates. I want to point that out, right? This is ongoing. It's not over. And as we pointed out with the current outbreak, this is predominantly infecting children. We also read that we are not doing such a great job outside of Africa of diagnosing cases of Mpox with the study. A seroprevalence study indicates a high proportion of clinically undiagnosed Mpox infections in men who have sex with men in Berlin, Germany. This was published in BMC Infectious Disease. So they do this seroprevalence study to say, okay, so what's how many people actually got infected? And then let's see how many people actually got diagnosed. We only diagnosed about 7% of the people that had a positive serology. So over 90%, we're just missing it. And then I'm going to leave in a link here to the WHO Africa Mpox surveillance website. And not only can you see that the number of cases is just rising, but you can actually see that it isn't just the DRC anymore. You can actually see a lot of other countries starting to join here. So, And then we even have a nice map. I'll even links to this too, and you can see really where's active outbreak, in all different parts. And it's actually covering a good swath of Africa currently with active outbreaks. All right, Marburg. This is a challenging situation here, right? So last week we had 58 confirmed cases. Now we're up to 62. Really jumped in quickly here with the attempt to get a vaccine study up and running. The real challenge, right, is will there be ongoing cases? Will we be able to figure out whether the vaccines work or not? Or is this just going to pop up the next time? Were we quick enough with those vaccine doses? So
And notice they only have distributed 700 plus doses. That's not a lot.
It's really not a lot. It's not a lot. Yeah. Yeah. So I feel like that needs to be part of pandemic preparedness, right? Like particularly diseases that we know about. Like this is the time when the vaccines need to be there like right away.
Yeah, but in this case, right to Marburg, you hardly see any infections.
Yeah.
This is pretty rare. So no company wants to invest. So this is something where governments have to engage in partnerships, right?
Yep. Yeah, no, definitely. Whooping. How do we pronounce that? Whooping cough.
Whooping cough.
Whooping cough or pertussis. And actually, it's important to know the two names because a friend of mine was looking to get vaccinated. He's like, they don't have pertussis, but they do have this whooping cough vaccine. I'm like, that's it. You go get the tetanus, diphtheria, whooping cough vaccine. But I want to point this out, get people aware of this. Still plagued with worst U.S. whooping cough outbreak in a decade has infected thousands. So far, we've got over 16,000 cases this year. It's already 4 times what we had last year. And there's a fun, interesting NPR article where they ask the experts, and experts say there are a number of possible explanations for the size of the current outbreak. I was curious what were people's thoughts. So, one, and I agree with this. Doctors are testing for whooping cough more, right? So you let people know, hey, this is out there, and if you don't test for it, you're not going to diagnose it. So people test for it, they make the diagnosis. So we're identifying more cases, and actually, I have to say. Kudos to a lot of the docs in our local area because we're seeing a lot of whooping cough. We're diagnosing whooping cough here. A lot of pediatric cases. Now, the other, I thought you would like this one, Vincent. It's possible that the bacterium that causes the disease has mutated.
Oh my God, that's such a cop-out.
Of course it's mutated. That's what they do. Has it really? I think.
Yeah, that's the point. It always mutates. So what you're saying is a mutation of consequence has occurred. So say it.
Yeah. Oh my gosh, that would be a little too sophisticated. But no, that's really what they're saying. Maybe the bacterium has changed in some way. Also, and I think this is clear, right? I didn't include a recent MMWR where they just talked about how the anti-science is taking hold and less vaccines in our kindergarten and younger. But no, people got behind on their vaccines during the pandemic. They haven't caught up, and people are not doing as good a job of getting vaccinated. So another quotation from this NPR article, one of the challenges that we have with the vaccine that protects against whooping cough is that it is you ready for this? A 5-dose series over the course of the first 6 years of life. So it does require regular visits to the primary care. This is from Dr. Eric Chow, the chief of epidemiology and immunization at the Seattle and King County Public Health Agency. And as I was pointing out, there still is a lot of vaccine hesitancy and anti-vaxxers out there that will not vaccinate their kids. This is from Tina Tan, a pediatric ID physician at Northwestern University and the president-elect of the ID Society of America.
So Daniel, when I was 8, my family went to Italy to visit my father's family, and they stuck me in a room with my cousin. So I was 8 and she was probably 7. She had whooping cough. And she coughed all night. I'm like, Mom, why are you putting me in there? Isn't it contagious? But I guess they had faith in the vaccine. But she sounded like she was whooping. Oh my gosh, I'd never heard a cough like that in my life.
Yeah, it's this really, I mean, it's a horrible cough, and often it can be so severe that we talk about this post-tussive, post-coughing vomiting.
Mm.
Yeah, so just cough, cough, cough to the point where you end up vomiting. And then another nickname for this is the 100-day cough. And so you get this, and the amount of post-infectious inflammation is such that you cough for 3 months. It's really hard for us to do anything about this.
Mm.
So it's a miserable infection. All right, COVID, and I've got the map right up here, and I was a little shocked when I saw the
Mm.
numbers this week, particularly Vermont.
Look at that.
Yeah, so in Vermont, I mean, this is as high as it goes. Over 8% of all deaths in Vermont this last week were due to COVID.
COVID.
And I'm going to point out, I'm going to say due to Omicron, right?
Mhm.
Because no one's really dying anymore, right? Oh my gosh, but
Yeah, of course
apparently they
not.
are. And, out there in Iowa, 4 to 6% of all deaths are due to Omicron. In Vermont this last week, over 8% of all deaths, more than, 1 in 12 deaths due to COVID.
Hmm.
So, in a little bit, I was preparing for a Medscape live talk that I'm going to do on, I think it's November 8th, with this British physician. And we're just talking about all these perceptions, right? So that's a lot of people dying, a large percent of people that are dying from COVID. But why aren't our ICUs full? Why aren't we seeing, that visual that we had last time? And we were talking about the fact that, during the early days in the pandemic, let's say I have an ICU with a 20 bed capacity, we would put 20 people in there and then they'd be in there for 2 to 3 months. And maybe, less than 10% of them would ever make it off the ventilators. But every day you walk in the ICU and it was a full ICU full of people with COVID. Now, what we realize is, hey, 90% of the time we were doing nobody any favors. So, when you look at these deaths, these are not people who ended up in the ICU with bells and whistles and alarms. These are elderly people, tend to be people over the age of 65. They tend to be people with some sort of a medical problem. They end up getting COVID. They end up getting hypoxic. Maybe they even get through that, and now they have a cardiac event or they have a stroke. We don't put them in an ICU for 2 to 3 months, sort of, so to speak, on display. We really make a decision about what's the best thing for them. And for a lot of people, not surviving, and spending the last 2 months of your life on a ventilator in the ICU is really not the best choice. Just want to point that out. Now, okay, in a sense, well, more than in a sense, death is sort of a late indicator with COVID. So we had our peak earlier. Apparently, they're still pretty high over there in the UK. But if we look at our wastewater, we really can see that we're heading into this lull that you and I were predicting, Vincent. The big is how wide will that trough be? Right? I think that's sort of our question. But it's really come down. And this week I actually put up, because you can go to this site, this cdc.gov wastewater, and I'll leave a link in, and you can actually zoom out, go all the way back to January 2022. And sort of see the pattern over the last 2 years. You can see, do we get 2 peaks? Do we get kind of a hump and a peak? And you could see this year we had a peak that started back in November, came down really into March. Then in June it started to go up, came down, and we're still on our way down at the moment. So we'll see where that goes.
And in the previous year, it came up, looks like late November, started rising.
Yeah. Yeah.
So
a
we'll
little
see about
different.
the future, Daniel.
Yeah. This was what prompted me to think about my quotation. But the wastewater, we may not be able to do a tremendous amount about this, but we can do a tremendous amount about people that end up in the hospital, right, and end up not surviving. So we'll talk a bit about that. But I will mention we're also starting to see influenza. I had a gentleman in his 40s, really sick with influenza, influenza type A. So. The variants were all in KP.3.1.1 territory. That's making up the bulk. And we did get some interesting, let's say an article I wanted to discuss this, relative effectiveness and waning of a third dose of mRNA COVID-19 vaccine in Medicare beneficiaries aged 65 years and older during the BA1, BA2 Omicron period, published in JID. So here the authors are going to look at the third dose of vaccine. So we've been talking for a while about the idea that these are really 3-dose, not just 2-dose vaccines. But what about some recent data here? So here they used Medicare claims data to conduct a retrospective cohort study in U.S. community-dwelling Medicare fee-for-service beneficiaries. So these are all folks 65 and older. They're looking at BA1, BA2 Omicron period, right? So we're going back in time to December 2021 through 2022. And they're going to look at this, and they're really going to ask this question, this relative vaccine effectiveness, like 3-dose versus 2-dose with the mRNA vaccine. Also going to get a little comparison between the Moderna and the Pfizer-BioNTech vaccines. They're going to look at 8 million eligible beneficiaries. 73% get 3-dose. And they're going to look at a couple different periods of time. And I think this is important. So they're going to look at 14 to 60 days since vaccination. And when they look at that, they're actually going to tell us that a third dose provided significant added benefit above or against COVID-19 related hospitalization. So our relative vaccine effectiveness here, our RVE, is for hospitalization, 77%. But I do want to point out, right? So you got the 2 doses. This is another drop. So you're already getting a benefit. This is an extra benefit. And for the Pfizer-BioNTech, for that 14 to 60 days, also 72.5. So greater than 70% benefit. So a little bit of comparison between the two. But then we go out a little farther. So now we're going to look at greater than 120 days. So for those with prior medically attended COVID-19 diagnosis, right? What if they get that added vaccine? We did see with Pfizer-BioNTech there was an added benefit for 120 days, while Moderna also provided some added benefit for greater than 120 days. And that added benefit was higher against death compared to less severe outcomes.
So Daniel, these vaccines were the original vaccines, I presume, right?
So let's go back here. So these are, and that's actually a good point too, right? So another thing I had, we actually have some data here we can talk about. We sort of follow these over time. But there's this, so in the UK, right? I think this was really sort of an interesting comment that the doc was making, because we're talking about here in the U.S. and other parts of the world. Like, do we have JN1? Do we have KP2? How close are we to the current variant? He's like, we got a whole bunch of vaccines we bought a while ago, and we're still going through those before we move on to any of these newer ones. And he was saying it's been quite a while, right, since we dealt with variants that those vaccines target, but we still seem to be getting protection.
Right.
And can you imagine what he was attributing it to? Not B cells, but some other type of cell, the T cell.
Well,
right, because T cells don't really care that much how close you are to the variant.
I also think the issue here is too, given the paper we did last week, there's probably no memory B cells being generated by these vaccines or by infection. So it's not surprising that after 60 days, you see reduced effectiveness. Right? Because you're simply not making antibodies. And then you're totally dependent on T cells. And if you're older, then, and that's this population, right? These are 65 and older. They have trouble making memory T cells.
Yep.
So, it's not really, if you don't make antibody, you can't blame the variant for immune evasion, right?
It's really true. Yeah, it's really true. Yeah. So,
but you can always, the T cells will always work, because they're not affected by the variants yet. If you're older, you're not really having memory T cells.
Yeah. Yeah. So no, I think, I think this is good. It's interesting. There's still sort of the B and the T cell. You got to be in a camp, right? You got to be on a team, right? But no, I think that as time goes by, we're starting to really appreciate
well, I think
that.
they work together, right? Daniel? Ideally,
imagine that.
Imagine that working together.
All right. So the other, I think this is really helpful, because sometimes people just say stuff, right? And I think it was Mark Twain, right? When people say things long enough, pretty soon, like there's sort of this crowd echo, and if you find yourself like sort of agreeing with the crowd, then you may want to rethink what's going on. But so there's a lot of people say a lot of things about, these antigen tests these days, such and such. So let's look at some actual science. So this is the article. SARS-CoV-2 antigen rapid detection test performance during the COVID-19 pandemic and the impact of COVID-19 vaccination. So this was published in eBiomedicine. And so I see this title and I'm thinking, I don't know. I mean, ideally, the way to really look at this would have been if you had the foresight back in 2020, right? To set up a study and say, you know what we do? We're gonna follow this for who knows how long this is going to go on, but we're gonna look at one center. We're going to keep all the variables the same, and we're going to follow the performance of these tests over the next several years, right? I mean, that's what you got to do. So I'm like, all right, but I'll read this anyway. So then I start to read this article, and wow, here we read that they actually performed a prospective assessment from 12 November 2020 to 30th June 2023 at a single center tertiary care hospital, looking at the sensitivity and specificity of the RDTs. So these are these rapid antigen tests from 3 manufacturers. They're even looking at 3 manufacturers, and they're going to compare these to the PCR as a reference standard. So I'm pretty impressed. I'm like, well, yeah, that's great. It all sounds good. But, you're going to have to do a lot of tests to really convince me here. So I look at this and check this out. They analyzed almost 80,000 paired results. And interesting enough, we actually find out that what we've been saying for a while is actually true. They confirm that a higher RNA copy number and being symptomatic, having COVID-19 symptoms, directly and significantly correlate with the likelihood of getting that positive antigen test. Now, what about age? What about sex? What about vaccination status? What about, the Omicron variants? Those did not correlate, right? So let's just make sure everyone gets the memo here. We're confirming what we know and pointing out that certain speculations are not supported by the data. So what do we know? So right up front, we have high RNA copy number is where we have the best sensitivity to those rapid tests. We also confirm that this is a great test for people who are symptomatic. But people are saying these other things, saying, now with these new variants, the tests just aren't as good. That's not true. There's no science that supports that. Also, now that people are vaccinated, these tests, they're just not as sensitive. Again, that's not true. And so I'll leave in the link to the article. You can actually go through. They have a really nice figure where you can actually look at sensitivity with all these different variables. And basically, if someone is symptomatic and you're testing them right early on when they have a high RNA copy number, you're going to have great sensitivity, particularly if you do what we recommend, is you test that first day of symptoms. Remember, so day 0 is when you start to feel off. Day 1 is that next day you still have symptoms. If that test is negative, 48 hours, you repeat a test again. And that's okay, because remember, all our data on improved outcomes is starting treatment relative to the day of your first positive test. So people get all upset. They say, oh my gosh, I started feeling a little crummy Monday night. I was negative on Tuesday. I didn't test positive till Thursday. You start your early antiviral on Thursday. You're going to get that greater than 90% reduction.
Best way to dispel myths is to get data.
Yes. So there's the science. All right. And leads right into what do we do? You get that positive test. In the UK, they actually do not have COVID guidelines. They don't have these wonderful national guidelines that we have. Now, we have these guidelines, but you know what? We don't follow them. So what's better? So we'll leave in links. We got those NIH COVID-19 treatment guidelines. We got the IDSA guidelines. I do want to point out that Fox News and New York Times do not have guidelines. Okay. So follow the guidelines. Number 1, Paxlovid. Number 2, remdesivir. 3, molnupiravir, convalescent plasma in certain circumstances. And as we've been talking about for a while, isolation, right? The first 5 days is when you see the most transmission. We don't see much transmission after day 5. And remember, that I was just talking to a physician today who was doing an antigen test to sort of test out of that isolation. Remember, if you, as I said to them, based upon some previous work, if you have a positive antigen test day 6 through 10, 50-50 chance you're going to have a positive viral culture. If you have a negative antigen test, 50-50 you're going to have a positive viral culture. So really not giving you the information that you think it gives you. All right. early inflammatory week. We have a little bit new here, and I think this is going to be an important one because the guidelines. Early on we had really rapidly changing guidelines. I mean, I think people were like dropping everything they were doing to like have these meetings and follow the grade criteria. Now we only meet so often, and even when we meet, it takes a while for someone to do their endnote references, and then even when you try to publish it, I don't know what's happened with peer review, but everyone's too busy to review papers, so it takes forever. But what do we know? One, steroids at the right time, right patient, right dose. So this is when a person starts to become hypoxic, the saturation's less than 94%. Anticoagulation guidelines, pulmonary support. But what about remdesivir? Has this changed? So early on, we had data that if you got your remdesivir in the first 7 days, it really made a difference. We had the pine tree data with about 80, 90% reduction in progression. But what about current day? So a couple updates here with the two articles. The first article is going to be remdesivir-associated survival outcomes among immunocompromised patients hospitalized for COVID-19, a real-world evidence from the Omicron-Domicron era, published in CID. So here they identified adult patients with immunocompromising conditions hospitalized for COVID-19 between December 2021 and February 2024, so really coming up to the wire here. Primary outcome was all-cause inpatient mortality examined in propensity score-matched patients. So we're looking at remdesivir versus non-remdesivir groups. You're going to do some subgroup analysis, patients with cancer, hematological malignancies, solid organ versus hematological stem cell transplant recipients. 28,966 patients included in the study. We've got 16,730, so 58% receiving remdesivir during the first 2 days of hospitalization. They're going to do this propensity score matching. So we've got 8,822 in the remdesivir, 8,822 in the non-remdesivir group. And what do we find? Hospitalized patients, remdesivir is associated with a significantly lower mortality among patients who didn't require oxygen. So our 14-day adjusted hazard ratio, 0.73, 28-day, 0.79, so a 27 and a 21% reduction in the folks that came in and were not on supplemental oxygen. Among those who are already on oxygen, supplemental oxygen, we had a 25 and a 22% reduction. And as they tell us, looking at subgroups, remdesivir was also associated with lower mortality in subgroups of patients with cancer, hematological malignancies, solid organ, and stem cell transplants.
This is
It's
quite late
not
in
too
infection,
late.
right, Daniel? It just shows that you can treat later.
Yeah. And I wonder what's going on. Like, is there still, is there actually like a viral cytopathic effect here? Or is this just still, we're getting in there and then getting the virus down, we're helping with more of the inflammation? I'm not sure I know the exact mechanism, but it's not too late. Also, we have the article, remdesivir effectiveness in reducing the risk of 30-day readmission in vulnerable patients hospitalized for COVID-19, a retrospective U.S. cohort study using propensity scores, published in CID. So I have to say, Vince, I'm going back like for this COVID-19 narrative review for JAMA and reviewing like all the clinical updates, just as I did, I guess, for the long COVID paper. And I just came across that part where I'm discussing with my wife how I was just put off by the clapping out. Remember, they would clap people out.
Mm-hmm.
It's all great. They sent him out the door with like no follow-up because no one was doing outpatient, and then they would get readmitted. Well, this is that issue. Nobody likes readmission. The hospital doesn't like readmission. The patient doesn't like readmission. I don't like readmission. So here they performed a retrospective study looking at 326,033 patients hospitalized for COVID during the study period. They end up including 210,586. Of these, about half, so 52%, were treated with remdesivir. And what do they see? Lower odds of 30-day COVID-19 related readmission. So they take that 4.2% readmission rate and they drop it to 3.3%. So a 22% reduction. They looked at the elderly population, right? A higher risk population. They dropped that from 4.7 to 3.7. They also looked at those with underlying immunocompromising conditions, point out that was a 6.2% readmission. They dropped that to 5.3. And this was
Daniel,
consistent. Didn't matter whether they came in needing oxygen, not needing oxygen.
what's the latest after symptom onset that you would give a patient remdesivir?
We really use 10 days as a
10?
cutoff from symptom onset. But sometimes it's hard to get that history. So, I mean, it's just such a safe medicine, no drug-drug interactions, no renal issues. Really turns out not a lot of hepatic issues. We will monitor that. But no, a lot of times we'll probably err on giving it, even if we're sort of not sure about the timing. And remember, it's 5 days when you're past that first 7. All right, and we have a couple here in the long COVID section, more than a couple, but number 1, measurement of circulating viral antigens post SARS-CoV-2 infection in a multi-cohort study published in CMI. So in this study, plasma serum samples were collected from adults participating in 4 independent studies at different time points, ranging from several days up to 14 months post SARS-CoV-2 infection. The primary outcome measure was to quantify SARS-CoV-2 antigens, including the S1 subunit of spike, full-length spike, and nucleocapsid in participant samples. The presence of 34 commonly reported PASC symptoms during the post-acute period were determined from participant surveys or chart reviews of electronic health records. So a little bit of an issue there about how good's that data, but of the 1,569 samples analyzed from 706 individuals infected with SARS-CoV-2, 21% were positive for either S1 spike or nucleocapsid. Spike was really predominantly what they were detecting. Among participants who reported at least one of the 34 PASC symptoms, 43% were antigen positive. And the presence of antigen was associated with the presence of one or more PASC symptoms with an odds ratio of 1.8. So they're about twice as likely, if you found someone antigen positive. So the article driving, this is a fun one. This is going to be in there with inhaling coffee and some of the other things that we learned about during the pandemic. But this is driving under the influence of COVID-19. And so now, they're going to do the breath analyzer and they're going to do a Nere's PCR to see if you should be out there on the road. But driving under the influence of COVID-19, exploring the impact of acute SARS-CoV-2 infection on road safety, published in the journal Neurology. So here the investigators looked at the correlation between acute COVID-19 cases and car crashes across 7 states. They also looked at vaccination rates. They found an association between acute COVID-19 and increased car crashes. Really, are you ready for this? Just to put this, I think, in a good context. Driving around with acute COVID was comparable to driving under the influence of alcohol. Which is really interesting, right? Because, you do these telehealth visits, right? And then we tell that patient, oh, we really want to start you on that Paxlovid. They're like, oh, I'll just drive, drunk, basically, over to that pharmacy. Like, no, don't let them drive. You got to get this delivered to the home. We don't want people driving around, basically drunk.
That's very interesting.
Yeah. So, all right. And then this is going to be our last one. And this is, we have the article, Long COVID, Facts and Findings, a large-scale online survey in 74,075 Chinese participants, along with the commentary, Long COVID is a significant health crisis in China, too. So I'm going to leave links to both of these. But this was published in the journal The Lancet, Regional Health, Western Pacific. And the first sentence of the commentary, I think, is really powerful. Long COVID, the constellation of long-term health effects caused by SARS-CoV-2 infection, is a significant global health crisis affecting at least 400 million individuals worldwide, with a cost of $1 trillion, equivalent to 1% of the global gross domestic product. And they quote this first line from the article Long COVID Science, Research, and Policy that was published in August in Nature Medicine. The article itself is a retrospective study where they used an online questionnaire to investigate SARS-CoV-2 infection status and long COVID symptoms among 74,075 Chinese residents over a one-year period. They analyzed almost 70,000 responses. They found somewhere in the range of 10 to 30% reported long COVID symptoms. They're including some folks in there with repeated infection. The most frequent long COVID symptom was fatigue. That was 30%. Memory decline, 28%. Decreased exercise capacity, that's 18%. Brain fog, 17%. Finding stuff that I'd say consistent with what we know so far. Women were more likely to experience long COVID. Symptoms varied by age group, except we were seeing sleep disorders, muscle joint pain more common in the older folks. And what were risk factors? Underlying disease, alcohol consumption, smoking, and the severity of that acute infection. And yes, reinfection may have been associated with milder symptoms, but it led to a higher incidence and severity of long COVID. And vaccination, particularly multiple boosters, significantly reduced long-term symptoms by 30 to 70%. So, all right, I will wrap us up. No one is safe until everyone is safe. We're still in October. There's about 2 weeks left. We're in our Floating Doctors fundraiser, August, September, October. We're hoping to get up to that level where we can double those donations up to a maximum donation of $20,000.
It's time for your questions. For Daniel, you can send yours to daniel@microbe.tv. Lisa writes, my husband and I are both over 70, live in Canada. We've been vaccinated 6 or 7 times against COVID, and I've had COVID twice. Our latest vaccination was 6 months ago. After that, we got COVID at the end of June. We got Paxlovid. Here in Quebec, the government's not offering Novavax. If we wish to get vaccinated, is it worthwhile to get another mRNA dose? We understand disease will not be prevented. Aside from age, I have asthma. My husband has arthritis. We'll get the flu shot for sure, but I'm not convinced that a 7th or 8th vaccine dose is timely.
Yeah. So, what are our thoughts? What are our recommendations? So, so this is a sort of a scenario that a lot of people are dealing with. Is so there have been vaccinations in the past. There was an infection during this summer spring peak, but that was back in June. So July, August, September, October. So we're about 4 months out from that. What we're thinking is these mRNA vaccines may not trigger the development of these long-lived plasma cells in our bone marrow, but they do for a period of time boost the antibodies. There is a temporary reduction in the risk of symptomatic COVID. There also, as we talked about in our data, there is a temporary reduction in your risk of severe disease, kind of above that baseline. So we've already got a baseline, right? We've got a baseline of immunity, which you have this hybrid one, but we're recommending particularly for higher risk folks. But really, I have to say here in the U.S., we're sort of recommending across the board that everyone get a boost this fall. Hopefully that's going to prevent this winter peak that I am predicting, and Vincent with his optimism is hoping never happens.
Jason writes, during TWiV 1156, the 3-season efficacy of the GSK RSV vaccine was discussed, with a marked drop in efficacy by season 3. These results led to comments that a booster would be needed at some point. It was reported in a press release by GSK in 2023 that a booster after 1 year did not change observed efficacy in the vaccine versus unboosted. So if a booster at 1 year doesn't change it, why would that be? And what might that say about the efficacy of boosting later than 1 year? Do you think that the information we have so far about the vaccine might hint towards limitations in the long-term efficacy of this vaccine, even with boosting?
So these are good questions, and really, the question has a lot to do with what are we boosting and what's the durability. So you get your GSK vaccine, and we've talked about the GSK and Pfizer being these fusion protein-based vaccines. Your immune system sees the fusion protein, 2 things are going to happen, right? Your B cells are going to make the antibodies, your T cells are going to create some degree of memory. A year later, still going strong, so you get a booster right then. It doesn't matter at that first year because you're still there. Then we'll use 2020, I'm going to say. So 2020, let's say we started. 2021, whether we boost or not, we're doing great a year later. 2022, right? They're 2 years later, still doing well. But now as we're seeing 2020, that third season, we're really dropping to less than 50% protection. So do we boost, not necessarily 1 year in because we were still going strong, but do we boost every 2 years? Does that give us like a 2-year durability? And these are the things that we'll find out going forward. I hope there isn't some sort of, you only get your window and then you're done and you can't boost going forward, or hoping that this could be just something where it's an every 2-year shot, for instance.
Michael writes, love the show. Never miss it. Contributor to Microbe TV. Full-time primary doc here. I use Paxlovid frequently. Today I had a 67-year-old male well known to me. Fever 100.6, myalgia, headache, non-toxic in appearance, normal PE, COVID rapid antigen positive. For years on ustekinumab for Crohn's. As I went to prescribe Paxlo, I realized I had prescribed it to him just 22 days ago. Same scenario. In that episode, he defervesced quickly. He did, against my recommendations, repeatedly recheck his rapid antigen test at home and states, I saw it gradually go neg and confirmed neg twice after that. He's an engineer. He returned to work with a mask about day 6. He was fine until yesterday. I confirmed negs of strep, flu, and RSV, never had a cough. I sent off a PCR this morning. Because of the IL-12/23 inhibitor, I elected to repeat Paxlovid. Would you? If this is all one infection, why a late fever without any other findings? Is the IL-12/23 inhibition important to explaining the course?
Yeah. So that, this is a great email because it's sort of that whole, like, the whole detective part of being an infectious disease doc, trying to figure out with the clues what may or may not be going on here. And you don't always have the clues. So as I see here, you went ahead and you said, well, let's send off a PCR, and maybe you can even get somebody to read you the CT values, which might help sort this out. So I'm reviewing, right, all these clinical updates going back, and I'm back at the period of time when we were like having this discussion, can you get reinfected? And it really was like, took something to like prove it was really a reinfection. And like, who's got the sequence of the first infection? Because you can't get a repeat infection. Well, you can get repeat infections. And unfortunately, you get repeat infections as soon as 3 weeks afterwards. So we don't know at this point, is this just one of those early reinfections? This individual got infected and then boom, they got hit with another infection. Or is this just that, ongoing medium COVID inflammatory phase, and now they're shedding cells, which just happen to, maybe have antigen or maybe have an RNA, and maybe that CT value is going to help you out, right? Because this is an acute COVID. We're going to think CT values in the teens. We're going to think millions of RNA copy numbers. If it's just that inflammatory shedding, which we see, then maybe that's going to be lower. But I've got, patients who really have the same clinical course. PCR is negative, and it really is just this ongoing post-COVID inflammatory, so medium COVID that we see. So was it a mistake to give Paxlovid? I actually think it's reasonable pending that PCR. So better to give it to someone who needs it, immunocompromised person, than to, keep it in your pocket or leave it on the shelf where it doesn't help anyone.
Anne writes, I was interested in the recent discussion about the fact that the mRNA vaccines may not provide protection against infection that lasts as long as we hoped. In 2022, I timed my booster to protect me on vacation, only to catch it anyway, with a positive test 7 weeks after the booster. In 2023, did the same, tested positive 7 weeks after vaccination. Does this indicate that the flaw is my immune system rather than the vaccine, or does it imply that the virus is unusual or something else? I just got home today and see whether I've broken the cycle of testing positive the weekend after I return home.
Okay. I don't think this says anything's wrong with you. I mean, so, the thing, and we keep pointing out, is that vaccines prevent disease, and particularly severe disease. They don't necessarily prevent infection, right? And so the wonderful model for that, right, is the injectable polio vaccine. You're just as likely to get replicating virus in your gut and shed, But so the big thing here, and I think the thing you have to say is, okay, you may have gotten COVID, but we're anticipating, we're thinking that the severity of those infections is reduced by your vaccination. So don't feel like something is wrong with you. And I'm hoping you broke the 7-week curse cycle that you seem to be in.
Mm-hmm. And DJ writes, no medicine here, just a word nerd commenting. Doff and Don from Doff Thy Coats come from Do Off, and do on. On a related note, when I lived in rural Labrador, people also said dout the lights for turn off the lights, also a contraction of do out.
Oh, I love that.
Great. That's TWiV Weekly Clinical Update with Dr. Daniel Griffin. Thank you, Daniel.
Oh, thank you. And everyone, be safe.